Welcome, everyone. This is Paige Nuez. I'm Director of Family Empowerment at RettSyndrome.org. And on behalf of our Board of Directors and entire team, we're so pleased to bring you today's presentation on epilepsy, incidence, treatments, and research, presented by Dr. Eric Marsh, who is epileptologist, neurologist, researcher, jack of all trades, I should say, Rett-related at CHOP, and we couldn't have a better person with us today to cover this topic. So we know that epilepsy and seizures are particularly challenging in Rett syndrome. Do our children have them? Do they not have them? Is it an episode? Should I be treating it? Is it a one-time thing? Will they go away? We'll have a chance to hear Dr. Marsh's thoughts, evidence-based, on his experience in practice and as a PI for the natural history study in today's call. Before we get started, though, I would like to go over a few housekeeping items. I think everybody's attended a RettEd webinar at this point, but if not, let me give you a few technical pointers. The audio feed is open for our presenter only, so you don't have to worry about your background noise interfering with the presentation. And if you look to the upper right corner of your screen, you'll see the control panel window for GoToWebinar. We invite you to type your questions or comments into the question field throughout the presentation, and we will hold all questions until the end of Dr. Marsh's presentation. We should have plenty of time to answer everybody's questions. I hope you understand that he may not be able to address specific situations going on with your child without knowing them directly, but might be able to give some general advice. If we don't get to all of the questions, I will work with Dr. Marsh to prepare a QA document after the webcast today and get it posted onto the website. Our website address is www.rettsyndrome.org/RettEd, RettEd. And on that page, you'll see access to recordings of all past webinars from 2018, and the recording from today's webinar will be posted up there within a day or two. So if you want to go back and revisit it, or you want to share it with someone who wasn't able to make the call today, or you want to share it out with someone on your care team, your personal child's neurologist, please do. This information is absolutely meant to be shared and to educate as many people in the world about Rett syndrome, particularly on epilepsy and seizures, as we can. If the control window is distracting to you, you can minimize it or move the window and then expand it at any time if you wish to submit a question. So again, I'm going to underscore this point because it's asked frequently. The session is being recorded, and we will post the link to the recording along with a QA document if necessary to the RettEd webpage. If you're having any trouble hearing, please check and turn up the volume on your phone or device. And if you still have troubles, type the question in, and my colleague Andrea Reed is on the line and will help with some technical issues that you may experience throughout. So with this introduction, I would like to say, yeah, I think I covered all of the technical issues. So, and housekeeping. So Dr. Marsh, if you're ready, why don't I go ahead and turn the screen over to you and we'll get started on today's hot topic.
Okay.
Okay, we can hear you, and it should be.
Do you see it?
Okay, great. I am seeing your slides, very clear, wonderful. Please go ahead, and thank you for being with us today.
You're welcome, and thank you for inviting me. Again, as Paige said, my name is Eric Marsh. I am a child neurologist at the Children's Hospital of Philadelphia. I run our neurogenetics clinic and am a PI of the natural history study, both on the clinical side, but also on the electrophysiological biomarkers component. And I have did a epilepsy fellowship, so training in epilepsy. So I have a real interest in understanding the epilepsy in neurogenetic conditions, and particularly in Rett syndrome, and that's what we're going to talk about today. One of the things that I think is important, actually, why can I switch my slides? Oh, it's on. There we go. All right, and before I get started, just again want to thank Paige and RettSyndrome.org for hosting this education forum. I think it's very important for families to have access to good education about the conditions that are affecting their children. And thank everyone who's listening in advance for listening and taking the time out of your busy days to listen to what I have to say and asking good questions. I've already gotten some in advance, which were good questions. And so the objective of today's talk is to first kind of just give an overview of epilepsy and seizures in epilepsy, because it's one of those things where when, if your child has an event, it's suspicious for seizure, you go to the neurologist starts talking at you and often doesn't explain things. And there's a lot of background information I find that families, I assume they know, and sometimes they do, sometimes they don't. But I think it's important that we're all on the same level playing field. So I'll spend the first part of the talk kind of getting us all on the same page and giving some information, which I think is good to have for families with children who are having seizures. The next is just to talk a little bit more detail about some of the seizures and the types of seizures and syndromes, and then how that relates to Rett syndrome. Then going to discuss the epilepsy and Rett syndrome, and then go into treatments and aspects related to treatments. And then at the end, we'll spend a significant amount of time with your questions. So epilepsy is a common problem. It's the fourth most common neurologic disorder after stroke, Alzheimer's, and migraine. About 1 in 10 people will have a single seizure in their lifetime, and 1 in 26 people will develop epilepsy. There's over 150,000 people diagnosed with epilepsy each year, and 30 to 40% live with active seizures because treatments don't necessarily work for those patients, those people. So what is epilepsy? So epilepsy is a disorder characterized by the tendency to have recurrence, as in multiple times, unprovoked, meaning that you didn't get hit on the head right before you had a seizure, and a seizure. And epilepsy and seizure disorder are synonymous. A lot of people think they're separate things, but they actually are the same thing. So what is a seizure? So a seizure is a symptom of disturbance of the electrical activity of the brain. And this little diagram or image on the right shows the brain firing like lightning. And so a seizure is when there is coordinated electrical activity in the brain that makes it act and gives it a clinical symptom. Seizures can be clinical, as in they have a associated feature that a person witnessing it can see, or they could be subclinical, where it's just activating the brain, but it doesn't show up as an event that someone can witness. And seizures can be provoked by many things. So high fever, so a child who has febrile seizures, drug withdrawal, alcohol withdrawal, infections, or injury to the brain, like a bleed or a stroke, can provoke a seizure. But that is an epilepsy because you need to have unprovoked and repetitive seizures. So why do people develop epilepsy? So in about 60% of the cases, the cause remains unknown. In about 40%, we understand the cause, and this could be a result of old trauma. So if it's acute trauma, it's not epilepsy, but if it's old trauma, then that becomes epilepsy. Tumors or lesions in the brain, old sequela of infections to the brain, birth injury, or genetic causes. And so for all of your children or family members who may have Rett syndrome, the Rett syndrome is the cause of the epilepsy in these cases. And so genetic causes are becoming more and more understood, and Rett syndrome is a good example of a neurogenetic condition that causes epilepsy and recurrent seizures. So since we're here at first just talking about epilepsy in general, most children with epilepsy are neurotypical and can outgrow their epilepsy, and they may be seizure-free and off medications as adults. However, others do have brain issues, including neurodevelopmental delay, intellectual disabilities or cerebral palsy, multiple seizure types, and other factors such as anxiety, depression, or attention deficit disorder. And in children with neurogenetic conditions like Rett syndrome, they fall into that other group where they have other significant issues associated with their epilepsy. So we've now defined a seizure, defined epilepsy, and I'm going to go into a little bit more detail for the next few minutes about seizures and how we talk about them as neurologists. So again, so that you and your neurologist can be on the same page. So the first big classification of seizures is whether they're focal or partial or localization related, which means they start in one spot in the brain. And if you look in the figure on the right for A, you see there's a red focus, which says where the seizure starts, and then it can spread. So that's a partial seizure, also known as a focal seizure or localization-related seizure. And the other big group of seizures are generalized seizures. And this would be in B, where the seizure starts at a spot and then quickly goes to the whole brain at once. And we're still understanding how that happens and what the underlying mechanism of that is. But those are generally the two broad classifications of seizures. And with focal seizures, like I said, they start in one part of the brain. The symptoms are often referable to the part of the brain that is affected, and we'll get into a little bit more detail about that in the next couple slides. But then a seizure can rapidly spread to the rest of the brain, and this is called secondarily generalization, and that's shown by the middle image on the right, where a seizure starts in the focus, spreads down to the deep part of the brain, which then makes it go all over the brain instantaneously, and that's called secondarily generalization. And that can happen very fast, such that it's often difficult for a parent or even and the neurologist to differentiate between a seizure that starts focally but rapidly secondarily generalizes and a primary generalized seizure. So that's the big classification of seizures. And then within that are seizure types. And so seizures typically go through phases. And a partial seizure, a focal seizure, often goes through a set of phases. Sometimes in kids who have intellectual problems, they can't explain this, but the parents still see a difference in their child. So the first phase is often called an aura or a warning. And this is just a change that will happen in the child. And in an adult who, say, has temporal lobe epilepsy, they'll be able to verbalize that and say that they have a weird feeling in their stomach or a weird sensation that something's about to happen. Then the ictus, which is what happens during a seizure. So the ictus is the seizure itself. And then the post-ictus, or the post-ictal phase, is what happens after the seizure is over until the brain returns back to its baseline state. So often the neurologist will talk about ictal or interictal or post-ictal, and ictal and ictus are the same word. It's during the seizure. Interictal is the time between seizures, and post-ictal is the immediate time after. So these are words that your neurologist might have said, and just trying to clarify for everybody. So we now have these two big groups of seizures, generalized and focal. So what does that mean clinically? What does that mean to your child if your child has a generalized seizure versus a focal seizure? So generalized seizures, the most common type of generalized seizure is the generalized tonic-clonic seizure. Used to be called a grand mal seizure. Neurologists don't like to use that term anymore. We just like to call it generalized tonic-clonic seizure. And this can present, this is an example of an EEG, and you can see there's brain activity on the left side of the image that is kind of very organized, and then all of a sudden it goes crazy on the right side of the image, and that right side of the image is the generalized seizure. And generalized tonic-clonic seizure often it occurs with a loss of consciousness. Often the muscles stiffen, and that's the tonic phase. So the body becomes stiff. If you're standing, you often fall to the ground. And the body will stiffen. And then you get the clonic phase, which is the jerking part. And this is the rhythmic jerking you see with a tonic-clonic seizure. Associated with this, the child often, or adult, may start with a cry as the muscles stiffen. There can be a kind of a large exhale, which sounds like a hoarse cry. Breathing can become shallow. There can be drooling. There can be loss of, there can be incontinence of either bowel or bladder control. There could be periods where the child will become very pale or even turn blue around the lips or in the fingers. And these seizures typically last less than 2 minutes, usually between 30 seconds and 2 minutes. And over 90% of tonic-clonic seizures are short, less than 2 minutes in duration. And then when the seizure ends, the person's often confused, has a headache, sleepy, body is sore, can have difficulty speaking right after a convulsive seizure, a generalized tonic-clonic seizure. The other common type of generalized seizure is an absence seizure. And this is what people used to call a petit mal seizure. And this is just a staring spell. So there's a pause in activity with a blank stare. There's a brief lapse of awareness. Often associated with this blank stare are automatic movements, such as chewing movements or slow blinking or hand movements. And these are typically very short, last less than 30 seconds, usually 1 to 10 seconds. And these can be confused with daydreaming or inattentiveness, or even a child has ADD because they're not responding a lot throughout the day, and it looks like they're inattentive. Other generalized seizures, a myoclonic seizure. This is a brief muscle contraction. It can occur just a single one, or you can have a repetitive series of these in a cluster. They can affect a certain muscle group, such as just one arm or a leg or the trunk, and they're very brief little contractions. A tonic seizure is just where the body will stiffen or get posturing of a limb. And then an atonic seizure is a loss of tone. It's kind of the opposite of a tonic seizure. And this might result in a head dropping down towards the chest, the body falling, or just folding over in a sitting position if you just lose tone in the trunk. So those are the types of generalized seizures that people occur. And these are very common all in Rett syndrome. So the opposite, again, of generalized seizures, the other big group of seizures are focal seizures or partial seizures. And in these, the consciousness is often not impaired because they're starting just in one part of the brain and only a small part of the brain is involved. So the person can maintain awareness throughout the event. They will often have some involuntary movements. And then the symptoms can be associated with where in the brain the seizure starts. So if the seizure starts in the part of the brain that controls arm movements, you can get clonic or jerking movements of the arm. If the seizure starts in the part of the brain that is sensory, you might get tingling or weird sensation in the hand or the leg. And if it's in part of the brain that's more cognitively or emotionally involved, you can get weird feelings, fear, anxiety, or a feeling they can't explain. These type of spells can be confused with lots of different things. Historically, there are many artists like Dostoevsky, who was thought to have partial seizures that gave him weird sensations that he used to drive some of his writing, and many other artists historically are thought to have potentially had partial seizures, particularly temporal lobe seizures. And as I said, earlier when I was talking about the types of seizures, these partial seizures can spread rapidly. And if they do, the seizure then can look generalized. It can be a tonic-clonic seizure, it could be atonic or tonic. So it is often difficult for a parent or a physician to differentiate these. And we'll get into this a little bit more later, but even with EEG, this can sometimes be a challenge. And the importance of knowing whether a seizure is generalized, focal, or secondarily generalized is because it can change the way you treat the patient and the way you think about treating the patient. So it's important to understand this, and it's important to try to think about this. And so from a parental point of view, when you're watching your child have an event, to take note of things of what's the first thing that happens. Do they start with there's just a change in their activity, and they have twitching of one hand before they have a whole body convulsion? That can be very, very useful information for the neurologist to help decide what type of seizure the child is having, because once you know that, you can think about what drugs to best use. So you can get this information by EEG, but it's often very helpful to get it from the history that the parent or caregiver tells. So we now have talked about what is epilepsy, what is a seizure, what is epilepsy, the big classifications in seizures, and the type of seizures associated with those classifications. And then if you add on other features besides the seizures themselves, you get what we call a seizure syndrome. And within pediatrics, there's a whole lot of seizure syndromes that you may have or may not have heard about. And so the combination of the EEG, the seizures themselves, and other aspects of the child or the patient, such as whether they have intellectual problems or motor problems, altogether becomes a seizure syndrome, and we call it an electroclinical syndrome. And some common ones that you might have heard about are childhood absence epilepsy, benign Rolandic epilepsy, or Ohtahara syndrome, West syndrome, which is also called infantile spasm syndrome, Gervais syndrome, which has been in the news a lot because of cannabidiol and medical marijuana. And then two that I'm going to spend a second on because they have important relationship to Rett syndrome are Lennox-Gastaut syndrome and ESIS, or electrical status epilepticus of sleep. Some people also call this CWSW or continuous, or CSWS, continuous spike wave in sleep. Those are synonyms of each other. So what is Lennox-Gastaut syndrome? Lennox-Gastaut is one of these electroclinical syndromes or pediatric epilepsy syndromes. Starts in early childhood, often can evolve from infantile spasms, and there are multiple seizure types. These children have atonic seizures, tonic-clonic seizures, atypical absence, which are focal seizures, and then myoclonic seizures. There could be many causes of Lennox-Gastaut syndrome, including Rett syndrome. And a lot of Rett girls will meet the electroclinical diagnostic criteria of Lennox-Gastaut syndrome. And that becomes important, particularly when you're talking about drug approvals and if you can get access to a drug, which we'll go into a little bit later. Unfortunately, children with Lennox-Gastaut syndrome, their seizures often do not respond very well to medications, and it's a lifelong disorder. And the EEG features that one needs to have Lennox-Gastaut syndrome is a slow, what we call spike wave, and then bursts of fast activity. And so I have a number of girls in my clinic who are classic Rett syndrome, but then their EEG and their seizures have evolved into an LGS-like pattern. And so that overlap is something that we see not atypically, but it's one of those things where, the Rett syndrome is really what is important, because the LGS is just a description of what's going on in the child. But that can now be used for drug approval because certain drugs have an indication of seizures of LGS or Lennox-Gastaut syndrome. And then the other electroclinical syndrome that I want to just go into a little bit more detail about is this electrical status epilepticus asleep. And what this is when the EEG activates during sleep. So there can be discharges that occur when awake, but when these discharges become very frequent or near continuous or even continuous during sleep, we call that ESIS. And this can be focal, so just a small area of the brain can have this activation, or the discharges can be seen everywhere in the brain. And that is something that often happens with girls with Rett syndrome, is that when they go to sleep, they're between seizure EEG abnormalities can activate and cause brain dysfunction. Now, in the classic syndrome associated with ESIS, there can be behavioral language changes when the EEG becomes abnormal. And the question is, in Rett syndrome, is there that change associated with it? And I think yes, sometimes there is. Sometimes the EEG might be independent of what's going on in the child. Kids with ESIS can respond to oral steroids, valproic acid or Depakote or high-dose Valium at night. And like I said, this has been frequently reported in Rett syndrome. There was a study back in the 2000s which reported 27 kids. 5 of those girls had an EEG consistent with ESIS. And in that study, they talk about that they can potentially respond to those same medications. Other literature suggests that may or maybe not that the girls with Rett will respond. So it's something that it's a discussion to have with the neurologist about whether it's worth trying. And we'll go into that in a little more detail as well as this webinar goes on. So that is my overview of epilepsy in general. And now I'm going to go into the details of what we know about epilepsy and Rett syndrome. And this just shows some of the main papers that have been published about epilepsy and Rett syndrome. And the one which says brain in the middle is kind of the most recent paper that came out of the natural history study. And it's one of the largest studies on Rett syndrome and tells us a lot about their epilepsy. And it's consistent with previous studies, but it gives us even more confidence in understanding the epilepsy associated with Rett because it's a larger study. And so these are the 6 main studies that have been published with the most patients. And you see they're all relatively recent. There's a lot of older studies which had 20 patients here, 30 patients there, which are consistent with these, but I'm just focusing on these now just so you see kind of the number of patients that have been studied in these studies. So this top one, this Tarquinio et al., is the natural history study that from the last version of it, and there was over 778 classic Rett girls who were followed for 5.5, and that should be years, not years. And what they found in that study is up to 90% of girls with Rett syndrome developed epilepsy. From an earlier look at the same data, Dr. Glaze at Baylor published the first 493 patients. He was looking at them kind of at one time, whereas the Tarquinio paper looks at these girls over time, and I'm going to go into that in detail in a second. But in that first look, just if you pick out one period of time, 60% of the girls had epilepsy. But if you then follow those, that number goes up to 90% develop epilepsy. There is this paper from Nissenkorn, which had 97 patients, all out of Israel, with 72% having epilepsy. There's a paper in 2010 from Australia with 162 patients, 85%. So you can see the numbers are similar across these different papers that are all across the world. So an international collaboration group where the data was just to collect electronically, where there was even 1,200 patients, and then this paper from Italy. So the numbers are very similar. So as you are all very aware that epilepsy is common in Rett syndrome, with not everybody developing epilepsy though, with the highest numbers that we know of is about 90%. And that probably is the upper bound of the condition. And just a funny anecdote, when I started seeing the girls in the natural history study and being more methodical about looking at it, the first 10 girls I saw, none of them had seizures. And I was like, wait, maybe they're completely wrong with these numbers. But then as you see more and more people, you realize that these numbers are probably very accurate over time. So one question you ask is, does the type of mutation, does it relate to whether you are or are not going to develop epilepsy? And so this is from this Tarquinio paper, where they looked at the most common mutation types, and that's on that top row there with the R106W, R133C. Those are the different mutation types. It tells you what's happening to the gene on the protein level. And what they found with a complex analysis, taking into account the age of the patient and a lot of other things, that if you just look at mutation type is associated with epilepsy. But it was somewhat paradoxical, and some of the more severe mutations, they didn't necessarily always have epilepsy. But when they did a next level of analysis and looked at whether it was associated with the mutation by itself was associated, or is that related to when the child's the severity of the Rett syndrome, or when the child developed Rett syndrome, etc., you see that mutation is related, but in a complex way, so that by itself mutation is probably not predictive, but mutation along with other features can be predictive of whether a child's going to develop epilepsy or not. And then am I a little out of order here? So yeah, I'm going to skip ahead and then go back. And then the question is, does that tell you about when the child will develop seizures? And so this is from data from the same study, but not from that paper, which looks at age of onset of seizures. And so very, very few Rett girls develop seizures before the age of 3. In papers that have looked at this, it's typically girls without MECP2 mutations. Some girls who ended up having CDKL5 mutations can develop seizures before the age of 3. But most develop seizures after 3, with the peak time in the early adolescence age of developing seizures. But it's pretty, the amount of kids who develop seizures over these different ages is pretty stable once you get past 3 years of age, probably a little bit higher when you get to 5, and then 5 and up is pretty stable. So now going back to this figure, which is kind of the central figure from this Tarquinio paper, and it's a very pretty picture, and it's hard to understand. And I'm going to spend a second to explain it because it tells you a lot about epilepsy and Rett syndrome. So it's one picture that gives you a lot of information. So on this figure, every line going up and down, I don't know if you can see my cursor. It doesn't look like you can see my cursor. Every line going up and down is a single patient. So there's 790 lines on there. And the colors, as you can read below, tell you whether they had seizures, whether they had a history of seizures but are not seizing, whether they have active seizures, whether they had active seizures that stopped at some point, which is called remission, and whether they had active seizures and continuing to have active seizures. And you see on the left in blue, those are the patients who didn't have seizures. And in the lighter blue are those who had history of seizures but aren't seizing when they were in this study. And then as you move forward to the right are patients with active seizures. And once they started having seizures, they continue to have seizures their whole life. And these 3 middle ones, which are mixtures of colors, show you the different patterns that patients can have. Some girls started the study without having seizures, developed seizures, but then the seizures went away. Some girls started the study where they had previously had thought to have seizures, entered the study without seizures, the seizures started again, but then they went away again. And then there were those who entered the study having seizures, but then went into remission during the study. So this tells you that seizures fluctuate during Rett syndrome, and that there are some patients, and this number would be, 16% of patients who have continuous seizures their whole time throughout the duration of the study. And you can see on the left axis, this is time in years, where the patients who were followed the longest in that part of the study were up to 8 years. There are some patients who seize the entire time, but many who don't. So, the epilepsy is complex. It's not something that once you get it, you definitely are going to have seizures throughout your life, that they might fluctuate. And that's important to know when you think about treatment, and when do you treat, how often do you treat, when do you stop treating. This informs the neurologist and informs us that you have to realize that many patients will just go into remission. What this doesn't tell us is whether they went into remission because of a medication, or it just was the natural ebb and flow of seizures in Rett syndrome. And we're looking at this data more carefully to see if we can associate any medication or particular medications with the starting or stopping of seizures. And I'll show you a little bit about that in a little bit. Did that one. And then when you look at the seizure frequency in the group, and you look at how the worst seizure severity, 33% of patients would have daily or weekly seizures. Occasional seizures being between weekly and monthly was 16%. And then they're on a medication but are seizure-free is about 20%. So there's variety also, that some girls will have seizures that occur every day, and others will have much less frequent and sporadic seizures. And what type of seizures do girls with Rett syndrome get? And this is data that we've been analyzing from the newest part of the natural history study, or what we call the 5211 part of the study. And here it's actually lists the different colors are the 4 genetic groups that are in the natural history study. So CDKL5 in light blue, classic Rett in red, orange is FOXG1, and dark blue is MECP duplication. And on the bottom of the axis are absence seizures, atonic seizures, complex partial seizures. And so you see that in the red, so girls with Rett syndrome do not get infantile spasms, but they have, most commonly generalized seizures. So they're in the middle, where the red bar is the highest red bar there. They can also have complex partial seizures. They can also have tonic-clonic seizures. So they can get a variety of different seizure types. And when you look across all those papers that I mentioned earlier, it's all very consistent that Rett girls can have a variety of seizure types, with generalized seizures or complex partial seizures being the most common. Now, one caveat in this data is this is all by history. We don't have EEG or other clarification of the seizure type, so it's what the physician termed. And if you combined generalized and tonic-clonic, you see that is by far the most common type of seizure that girls with Rett syndrome get. So, that's a lot of talking about seizures, but one of the complicated parts of being a neurologist and treating girls with Rett syndrome is girls with Rett syndrome have a lot of unusual movements. So one big question that I always ask every time I see a girl with Rett syndrome is it a seizure? And not all unusual events are seizures. And in actuality, probably more than not, it's not likely to be a seizure in some way, if you include hand movements and breathing abnormalities and things that Rett girls do all the time. And one of the challenges is that the EEG is almost always abnormal in Rett syndrome. But the fact that the EEG is abnormal doesn't mean the child is having seizures, or should they be started on medication. We don't treat the EEG, or you shouldn't treat the EEG. You have to treat the child. So it is often necessary to capture an event on an EEG to see if the event is a seizure or is not a seizure, and then use that to choose whether it's time to treat or not to treat. So what can be confused as a seizure? Well, so breath holding, hyperventilation spells. Some girls will breath hold, and when they breath hold, they might stiffen a little bit. So is that a seizure, or is it just breath holding? Because if you get a little stiff and you turn blue, is that a tonic seizure, or is that a breath holding with a little cyanosis or a little turning blue? Girls, anyone who has cognitive issues often will stare off into space and not be quite responsive. Is that an absence seizure or a complex partial seizure? Or is it just staring and just behavioral? Events of screaming. So Rett girls are known to have periods where they'll just scream. Is that a seizure or is that not? Stiffening events, which can be dystonia, which is just a contraction of muscle groups, or it can be a tonic type seizure, shaking, tremulousness, falling. These are all things that can be confused between seizures. And these are all things that girls with Rett syndrome do a lot of. So you can imagine it can be complicated to sort these out. And video EEG, good history, the parent capturing events on their phone. When I started as a neurologist, you would ask someone to video it, and it would mean they'd have to break out their camcorder and try to video these things. And it wasn't easy to walk around with a big camcorder. Nowadays, with the ubiquity of phones and everyone having a video camera on their phone, it's something that becomes a very reasonable thing to ask families to do. So are there any other clues to tell whether it's a seizure or not? Is video EEG the only way? And no, there are other things to look at. So, really not responsive during a spell. And to that, I mean, not just calling your child's name or touching them, but potentially doing something a little more noxious. You never want to leave a mark, but, a little pinch or splashing water in the face. If they really don't respond to something more noxious, something that they would respond to when they're not having a seizure, that's an important thing to look out for. Whether they're sleepy afterwards, whether the movement's always the same. If it's exactly the same every time, that would be a hint that it's more like a seizure. If it's a little different every time, that would be a hint that it's maybe not a seizure. And then if they're making eye contact and they're, looking at you during the seizure, or during the event, maybe not a seizure. If it's not reproducible, it's not rhythmic, less likely to be a seizure. If they get back to themselves immediately after an event, less likely to be a seizure. So you can use all these things and tell the neurologist or the pediatrician about all these different things to help them decide whether it's a seizure or not. Because you don't want to be going into the hospital to get a video EEG every time there's a new event. You want to use these things. And if there's a new event and it happens once and it never happens again, or it happens really infrequently and it's different each time, it's unlikely to be a seizure. But if you're not sure, there's always a way to make a more definitive answer to this. And the last aspect of this is the EEG. And so the EEG in Rett syndrome changes with age and with stage. And this is an example from this Nissen-Korn paper from 2010, where it's the EEG on the same child over time. And, you guys are not EEG experts, but you could see, and you go from the upper left to the upper right to the lower left to the lower right, EEG kind of becomes a little crazier throughout the whole time. And girls with Rett syndrome, their EEG can evolve and it can become more active and more abnormal looking. And in D, in this lower right-hand corner, that's a slow spike wave pattern, which would be consistent with Lennox-Gastaut, to go back to what I was talking about earlier. So is there anything else that can help make a diagnosis or track seizures? And there is now becoming a bunch of technological aids that might become useful. And examples of these, I'm showing 3 examples here. So in the bottom right-hand corner is the Empatica E2 watch. This is a watch that looks at skin temperature, pulse, and movement to determine if a child is having a seizure. This next one is the MFit bed monitor that you'd put in a bed to see if a child is having a seizure when they're sleeping. And the top one is this brain sentinel device, which goes on the back of the arm, also measures similar things that the Empatica watch does. And we're learning more and more about these devices. They all have issues, though. They all have significant problems with false positives, meaning they'll tell you that your child is having a seizure even though they're not seizure. And they're all really good for convulsions or big seizures. They're not very good for smaller events. And these were all tested on otherwise neurotypical child. So in girls with Rett syndrome who are moving their hands or have dyskinetic, constant movements, the algorithms that are set up in these devices are not set up to take into account all those extra movements. So they wouldn't do very well in many cases with girls with Rett syndrome. As of now, as I'm aware, insurance isn't typically paying for these, so these are out-of-pocket expenses also. If a family really wants to try out one of these things, I often do encourage it, but tell them with all the caveats. And it's something where you might buy it and then end up throwing it out shortly thereafter because it just doesn't really do the job for you. And as long as that cost is not a problem, it's something that, if a family wants to experiment with, I'm okay with letting them do that. And then the other aid is, using online technology and mobile technology to help with the treatment of epilepsy. And the way, if you're treating epilepsy, you need to know how often a child is seizing. And as just in life in general, no one's really good at remembering, what they did a week ago or a month ago. And if you particularly want to say, what did you eat a week ago or a month ago, you're not going to remember that. And in children with seizures where parents are very busy and there's a lot going on, remembering exactly how often a child is having seizures is difficult. And if you make a medication adjustment and you don't really know how often they were having seizures beforehand, you don't really know if your medication adjustment is working. So I often try to convince families to keep a seizure diary. It can be done on paper where they just write it down, but there are a whole bunch of good technological aids. SeizureTracker.com, and this is a figure from SeizureTracker.com that shows that you can put in seizures and medications and medication dosage over time, and that you can then forward to the neurologist who can use this to determine whether there's any changes in the frequency or the type of events that are happening. Another one is called EpilepsyJournal.com, which is actually out of the Epilepsy Foundation in Minnesota, Seizure First Aid. And if you just do seizure in the iTunes store, a whole bunch of apps come up that may or may not be useful. I do recommend to families SeizureTracker.com. And then a thing that no one likes to talk about, but I will just briefly say that seizures can result in death due to a very prolonged seizure or status epilepticus, or a complication of a seizure, such as the person's in a bathtub or in a pool when they have a seizure, can result in death. And then there also can be death due what's called sudden unexplained death due to epilepsy, or SUDEP. And this is someone who has known epilepsy, who has epilepsy where the seizures don't respond to medication. They're at higher risk for just potentially dying from their epilepsy, where they're just often found in the bed in the morning, having passed away. And there's a lot of people doing research on this and trying to understand why this happens better and what we can do to prevent it or what we can do to monitor it. But right now, unfortunately, it's just something that exists and is out there. And, the best way to prevent it is to try to do your best job of treating the underlying epilepsy. And with that, now we're going to talk about treatments, and I'm going longer than I thought I would. I talked more about this. So we're going to go over current treatment options, surgery, diet, and the vagus nerve stimulator. So I think you all probably aware of this, but one important thing we talk about treatment is first aid during a seizure. Most seizures are not medical emergencies, but basic first aid, depends on whether there's no change of awareness, loss of consciousness, where it's happening. You don't want to give anything by mouth, and you don't need to do anything if it's just a brief little event, or the person's aware and talking to you, or aware and communicating with you throughout the event. If the person has a convulsive seizure or a bigger seizure, then you want to observe them. You want to try to time how long it's taking, because that's important information for the neurologist. And then if it's going on for more than a couple of minutes, call 911. And again, if you know your child's seizures are always 5 minutes long, you don't necessarily have to call 911 after a few minutes. You can wait because you know what's going on with your child. But that's at the discretion of the parent and the caregiver, what they're comfortable with and what they need to do. You want to just make sure the airway is unobstructed, so tilting the head back or tilting the head to the side. You want to protect the person so that they don't hit anything if their body is shaking, and remain with the person. Don't put anything in their mouth, do not restrain them, and do not leave the person. So those are just general comments about seizure first aid. And then, emergencies is if the seizures are going on for a prolonged period of time, which is called status epilepticus, or there's a prolonged cluster of seizures. And then emergencies, if a seizure happens on the stairs and someone falls downstairs, that can become an emergency due to the injury that occurs from it. And then status epilepticus is an emergency, and this is a seizure that's going on for more than 5 minutes, or multiple seizures without recovery to baseline in between. And this is something where you'd want to get to the emergency room or the hospital, or be in communication with your neurologist. One important thing to state here is you should never put someone in a car and drive to the emergency room on your own with a child seizing, because that will be the one time you get a flat or get stuck in traffic. And so it's a dangerous thing to do. You should always, at that point, if you need to transport the child, transport them by the emergency medical services. So just kind of generally treating kids with epilepsy, and adults, about 2/3 of patients respond to medications, and 1/3 of patients can have medication-resistant seizures, we call medically refractory, treatment-resistant. There's a whole bunch of terms people use. And the numbers in Rett syndrome is actually very similar to that many Rett girls respond to medication. There's some papers that say up to 60% can become seizure-free on medications, and 30% can become medication-resistant. The figure I showed you before had about 20%, so the numbers varied there. And, as that figure I showed before, is that seizures fluctuate in Rett syndrome. So whether to know for sure whether it's the medication or just the natural fluctuation of things is hard to sometimes know. But you can see that in general, treating girls with Rett syndrome and kids in general with epilepsy have similar type of responsiveness. Some general principles when you talk about treating. So I always tell families, you treat the child, not the EEG, and that's particularly important in Rett syndrome because the EEG is abnormal. And we know the EEG is going to be abnormal, and we know we can't change the EEG. So you don't treat the EEG, you treat the child. When you start treating seizures, the goal is no seizures, no side effects. There are times where, that goal has to change over time. And you have to decide to balance seizure control with quality of life. And one thing that I particularly like to try to do with my patients, but it's not always possible, is avoiding polytherapy. Avoiding having a child on 4 medications. I try to keep my patients on 1 or 2 medications, and frequently we'll just keep them on 2 and try to adjust medications. But sometimes, seizures are really bad, and you add medications and you seem to take one off and seizures get worse and you get stuck on more than 2 medications. But it's something to avoid, because if 2 medicines aren't working, adding the third one, you probably should take one off, because if they weren't working, they don't need to be on. So those are kind of general principles. And the last thing is, it's a decision on whether to chase seizures. And if a child has a seizure, every 4 months, without a medication, do they need a medication? Is it okay to just watch them? And that's a discussion to have with the neurologist. In my opinion, I think it is okay just to watch that if they're very infrequent seizures and they're not impacting the child's quality of life or the family's quality of life. So you don't necessarily have to chase seizures. It becomes a discussion with the neurologist. And what makes one of the things that makes treating seizures challenging is that things can make seizures worse. So missing medications, stress, sleep deprivation, puberty, drug interactions, recreational drugs, things like that can make seizures worse. I mean, over the years, I've had families tell me that every time there's a full moon, their children have seizures, and then multiple families have said that. I think there's probably something to that. There's not great data on it, but there's probably something to it. Changes in weather, constipation are all things that can potentially lower the seizure threshold and bring on seizures, which makes it challenging, because do you up meds to cover those times or do you not? And how do you deal with those type of situations? And again, this is something that is worth noting and worth having a discussion with the neurologist about. There's no right answer for how you deal with those things. It becomes a quality of life and how best to handle it for each individual child. So there's a lot of seizure medications that are out there. I'm not going to go discuss these at all, but these are the older ones, and some of these are still very good seizure medications. They often have more side effects than the newer ones, but they're very good seizure medications that should be considered and used. And then the newer list of seizure medications, and this is up to date minus the most recent approval, which is cannabidiol, which we're going to go into a little bit more detail in a second. But this is the newer list of medications. So there's a lot of medications out there. And, as I said, in the general principles aspect, you want no seizures and no side effects. So if a medication stops seizures, but your child's sleeping all the time, that's not acceptable. And side effects can be unpredictable. They can be dose dependent, and some are dose independent, that they happen what we call idiosyncratically or out of the blue. Like I said, generally the newer medications have fewer side effects than some of the older ones. And many medications, people report behavior or mood changes. And this is often difficult to sort out because, are the mood changes due and the behavior changes due to the worsening seizures or to the medication? Or if the child was having lots of seizures, the seizures stopped, maybe it's the way the brain's responding to that and not necessarily the medication that stopped the seizures. So it's a complex interaction that occurs. The older medications, we know about some long-term effects on bone health, bone density, but in general, otherwise long-term, these medications are safe. And the newer medications, we have less data on long-term effects, but it's a weighting between seizures and side effects and long-term effects. And I think we all agree that in children who are having frequent seizures, the benefits of these medications outweigh if there's small long-term risks that we're not aware of. But a lot of these medications now people have been following people for 10, 20 years without any significant long-term side effects appearing. And you should report any changes in your child to the neurologist when you start a medication. So if they're more sleepy, if they're not tolerating their feeds, whatever it is, you should report it to the neurologist. They need to know. The decision might be made not to make any changes, but it's an important thing to know. And this is just the list of common side effects. You guys have probably seen many of these that can happen. And again, just report anything you see, and it can be discussion on whether or not these are drug related or not drug related. And if you start a new medication, if there's any significant changes, a rash, fever, prolonged sore throat, things like that, that you want to contact your the child's pediatrician, healthcare provider right away about. And so, do we know anything about drugs in Rett syndrome? And the answer is no, we don't know much. All these studies that have been done have listed drugs, and we know that girls with Rett syndrome are on all the drugs that children with epilepsy are on. This is some data that Dr. Tarquinio pulled together, which starts to look at the likelihood of being seizure-free on a particular medication. And if the medications bars there are above 1, it suggests that you potentially are more likely to become seizure-free than not on that medication. So the medications on the left are suggestive, potentially being more effective than the medications on the right. However, this data, we're looking at this again, and we're trying to analyze this to see if we can control for some of the issues like length of time and the order in which the medications were started, because if 60% of the patients can become seizure-free on the first medication and they were started on levetiracetam or Keppra first, well, that's going to look good, even though it might be no more effective than clobazam, which was started as the 4th medication in a person who's going to continue to have seizures. So this needs to be analyzed a little bit further, but there's not much else in terms of medication-specific understanding for Rett syndrome. And then something that's really big in the news and that people really want to talk about is medical marijuana for Rett syndrome. And the figure in the upper right is from the Charlotte Figge, who became a viral sensation about her parents talking about their response with a strain of marijuana that was high in CBD and how well she did on it. And subsequent to that, there's been a lot of study of purified cannabidiol from the medical marijuana plant in pediatric epilepsies. This figure down below is from a paper that I did with Dr. Davinsky at NYU and people from Boston and from Chicago and UCSF, where we looked at cannabidiol in a whole variety of early onset severe seizures. There was a couple girls in Rett in this group, and you see this is change in seizure frequency on the left. And see, most the lines are below 0, which means most patients had a positive response. But only a few, which is all the way to the right, were seizure-free. It was like 8 patients out of this 135 that were seizure-free. So it is a medication that medical marijuana, cannabidiol particularly, is something that can be effective. And do we know anything about Rett specifically? Well, there's been these 4 phase 3, which are the gold standard clinical trials that the FDA requires a company to do, that have been done. And it's now approved for Lennox-Gastaut syndrome and Dravet syndrome. The approval was at the end of June, and believe that the drug will be on the market pretty soon. What we've learned from all this research is that cannabidiol inhibits some of the enzymes in the liver that metabolizes other drugs. So it's important to talk to and inform your neurologist about using a medical marijuana preparation, because it can have some significant interactions that can even potentially be dangerous with Depakote. So it's something that's important to inform them about. I particularly am not a big fan of just getting things on the internet or from a state dispensary, because you don't really know what you're getting there. There's no oversight to make sure that people are providing what they say they're providing. And you hope everyone wants to do well and they don't want to mess with kids who are sick, and they wouldn't do something like provide a medication which isn't what it says it is. But unfortunately, people have actually tested a lot of the online providers of CBD oils and tested it compared to what they said was in it. And it turns out more often than not, it's not what it says it is. And that makes it difficult as a physician to recommend because you don't know what you're going to get. You wouldn't go to your local drugstore to get an antibiotic and then not give you what you want. You would never do that. So I feel the same way about these state dispensaries. Fortunately, there's a lot of people who are interested in studying these things with really reproducible preparations besides GW Pharma. So there's a lot of interest of this going forward. And so, does this work for Rett syndrome? Well, in the data that I'm aware of, there's not that many patients who've been exposed in our databases. In the ones that have, it does seem like it can have the same effect that it has with LGS or Dravet, so that it can be effective, but again, it's not the cure-all for children with epilepsy. And the other big question that comes up when people talk about cannabidiol is, does it have non-seizure effects? Does it improve attention? Does it improve anxiety? Does it improve stereotypies? And, in my experience with these, with all the children that we've treated with severe epilepsies over the last 4 years, there definitely does seem to be something positive about it. I don't, we're trying to quantify that. We're trying to get more data because it's important to have data to, make claims about, but it's something that needs to be studied. And it is something that GW Pharma, or what's called Greenwich Pharma in the United States, wants to study in Rett syndrome. So there is plans for a CBD in Rett syndrome study in the near future, hopefully starting at the end of this year or the beginning of 2019. And then the last question when you talk about cannabidiol is, CBD versus THC. THC is the component of medical marijuana that gets you high. Do you need some THC in your CBD to stop seizures? Would it be better if there was some THC there? The answer is we don't know. And that we know that, almost pure, 99% pure CBD is effective for stopping seizures. It, in 60% of patients have greater than a 50% reduction in seizures, and particularly in those with LGS and Dravet, but in a lot of these early onset seizure disorders. Would it be better if you add THC? And the answer is we don't know right now. It's an interesting question, one that I hope some of these companies will start to address by providing a very reproducible compound that has mostly CBD, but a little bit of THC and different levels of THC, and see if it improves it, or does it get the same seizure effect and potentially worse cognitive or behavioral effects because of the effects of THC. One thing that often comes up when you talk to families about treating seizures is generic versus brand name. A lot of the newer medications are now on generic. And in most situations, generic forms are appropriate to use. Where that changes, if someone's on a brand name and doing well, changing to generic can be tricky because the generic doesn't have to exactly match the brand name. So it's just switching formulations is the major concern. And so if someone's doing really well on one formulation, then it's appropriate for the neurologist to write brand medically necessary. But when you're starting a new medication, it's perfectly fine to start on generic as long as you stay on that generic formulation. And then if we go away from medications, dietary therapies such as the ketogenic diet can be effective for children with severe epilepsy. And there's kind of three forms of this dietary therapy. There's the full ketogenic diet, which is this very high fat, low protein, low carbohydrate diet, and can be used to treat difficult to control epilepsy. It is, in kids who eat by mouth, can be a challenge because it's a very restricted diet, but people do very well with it. Modified Atkins diet is a modification of the traditional ketogenic diet. It's less severe, less extreme than the ketogenic diet, but it also can be effective. And there's some research out of Johns Hopkins University which shows that it can be a pretty effective diet. And then a low glycemic index diet is a variation. It's a low carbohydrate diet that is much less restrictive than the ketogenic diet, and also some data to suggest that it could be effective. And what about these? Oh, and the way the ketogenic diet works is it produces ketones that from unknown ways potentially modify the brain to make the brain less prone to develop seizures. It's effective for all seizure types, but when you start it, it is a challenge because you're starving the person, and that can cause medical problems. And staying on it can be problematic, and it does have side effects. So constipation, metabolic acidosis, weight changes, kidney stones are all potential side effects of the ketogenic diet. And what do we know about the ketogenic diet in Rett syndrome? That there are 3 reports with a variety of patients, all small numbers of patients, but in it, the data suggests that it can have the same type of efficacy it can have in other children with severe epilepsy, and that it can be used effectively in Rett syndrome. And then the last thing before going to the questions is just epilepsy surgery, and I'll be quick with this because there's not much to say, but resective epilepsy surgery, where you remove a piece of the brain, is considered for people with medication-resistant focal epilepsy, and it wouldn't be something that's appropriate for Rett syndrome. But implantable devices such as the vagal nerve stimulation, responsive neurostimulation, or stimulation of the anterior nucleus of the thalamus, the later 2, which were both just approved by the FDA for use in humans after years of studies in adults. They're both approved for 16 or 18 and up, so not for children quite yet. These are things that can be considered. And the VNS, which has been around for a long time now, is a device that gets put around the vagus nerve. The device sits in the upper chest, and it just periodically stimulates the vagus nerve. And this modulates brain activity, which reportedly reduces seizure frequency. Side effects is that you can have hoarseness or coughing or shortness of breath. And there's one paper that looked at 7 Rett girls with VNS placement who had it from 1 to 6 years, and 6 of 7 had a greater than 50% change in their seizure frequency, but that's over 6 years. And as the data I showed earlier showed, that there's fluctuations over time. These kids were also probably put on different medications throughout that time. So it's hard to know what's the VNS and what's not, but the VNS is a relatively benign device. And if kids' seizures are really bad, it's something that should be considered. So with that, I am going to end the lecture part of this, and we can start taking some questions. So thank you all for listening. I went a little longer than I expected to, so sorry about that.
No problems, Dr. Marsh. I think everyone was paying great attention, and there's a ton of information. I have a question that I should have prepped with you beforehand that wasn't addressed in your slides, so not to put you on the spot, but can you talk a little bit about rescue medications? And maybe I missed that in your slide, but so with families, who are in that 20 to 30% of intractable epilepsy and, kind of get very comfortable with using rescue medications versus families that are new. And you also then bring in to play school staff who have differing opinions and different rules and regulations about the use of rescue medications. Could you talk about that for just a moment?
Yeah, no, I did not bring that up when I was in the slides, and I should have. But yeah, so, rescue medications are used for 2 purposes. One purpose is to stop a seizure that's going on for more than 5 minutes or more than 2 minutes. And the other purpose is if a child gets a cluster of, say, tonic seizures or atonic or myoclonic seizures, and the typical cluster lasts 10 minutes, but the cluster is going on longer, to give a rescue medication. Rescue medications are typically Valium-like drugs or benzodiazepines, and these are medications that suppress brain activity and cause seizures to stop. The one approved rescue medication is Diastat, which is rectal Valium. It's a gel that gets administered rectally, but there's a lot of interest in other rescue medications, doing things intranasally or even between the cheek and gum. as potential rescue medications. So for my patients, if the child has clusters or prolonged seizures, I do prescribe a rescue medication. I often do two things. I often prescribe Diastat because the school it's an approved medication and it's something that schools are often trained at and know how to do. But I often sometimes will also approve midazolam or Versed in the liquid form that can then be put, can be aerosolized using a device that you can get online to go into the nose. And people are actually doing clinical trials on exactly that. But they need FDA approval before they can market it as such. And that has the advantage of you don't have to pull your pants down. It's cleaner, it's neater than Diastat. But a lot of schools won't do that because it's not approved. So they won't allow that. So then that's something that the families can use at home. And what I talk to families about is your child best. If their seizures all stop before 6 minutes, to make a plan where if it goes past 5 minutes, then you start the process of doing it. If the seizures, if they go past 2 minutes, aren't going to stop without a rescue, then you give the rescue at 2 minutes. And families know their children best, so I work with them to come up with what's the best plan, and then we write down a seizure action plan, which we give to the school. And sometimes it takes negotiation with schools to agree with plans, but it is an important part of your whole treatment regimen to have a rescue plan in place that works for the family, the child, and the school as well.
Great. Thank you. Thanks so much for talking about that. Okay, so we've got and if anyone has any further questions on that topic, type them in and we'll try to get to them in the next 12 minutes. And we have about 12 questions in the queue. So there you go, Dr. Marsh. I'll read them quickly and you can take about a minute per answer. Or, like I said, I'm joking, we'll create a QA document.
Mm-hmm.
You answered many of these questions as you went into your slides, so some of them will be repetitive, but they're obviously important to folks. So let's see if we can hit on them again. Okay, so the first one, I'm just going to go in order of the queue. My daughter is 29 years old, and the question is, can a change in bowel habits bring on seizures? Same with change in environment, such as moving to a different home. So actually, there's a couple of questions in the queue about what seem to be the biggest seizure triggers in girls and women with Rett syndrome. You have that whole list, but what do you seem to be the most common?
Yeah, so it is something I wish there was more data on, but bowel changes in bowel habits, worsening constipation, definitely can be triggers for seizures, and it makes sense. Your gut is innervated by the vagus nerve. We know you can stimulate the vagus nerve to modulate seizures. It makes sense that if your gut is expanding because it's getting more constipated, that could send a signal to the brain that could potentially induce seizures. But I think the biggest triggers are typically stress and anxiety, and lack of sleep are the two biggest seizures. You are all very aware that sleep is a significant problem in Rett syndrome, but if a child has a typical sleep pattern, even if it's interrupted, if it becomes more interrupted, that can become a problem with seizures. And then infections. So a cold, probably the most common trigger of seizures are an infection, and even a mild infection. The kid just has the sniffles and they're not otherwise impaired. That virus can induce an immune response that can lower the seizure threshold and cause seizures. So if I were to pick one thing that is the most common, it's probably infection and even mild infections. And after that, it would be sleep or stress. But changes in bowel habits can definitely do it. Moving, that's a type of stress. So could that do it? Absolutely, because that is a type of stress. And Rett girls who are so aware of their environment, moving could be very stressful, and that could potentially shift the state they're in and the balance they're in and cause increased seizures.
Okay, great. Thank you. A follow-on question to that is, so if you have an adult who's been through a number of seizure medications and has had varying levels of success, that seizures have returned. At this point in time, with the knowledge, with the announcement that there might be a clinical trial coming for CBD, would you recommend to families at this point, if they're in this situation, that they should give medical marijuana a try, and how, if you could again talk about how they would approach that conversation with their neurologist?
Yeah, so if your child's having seizures, their seizures returned, I wouldn't wait for a clinical trial, because a company will make an announcement of a time, and those timelines often change. So I wouldn't wait unless your local neurologist says they're about to start enrolling. I wouldn't wait for that. So just get that out of the way. Then the next thing is, does your child meet the electroclinical characteristics of Lennox-Gastaut? Because then the cannabidiol will be out on the market, hopefully very soon. And in that case, that might be a very good next choice of medication. If your child doesn't meet the electroclinical characteristics of Lennox-Gastaut syndrome, then going to an online dispensary, as I said, I'm not the biggest fan of that, just because you don't know what you're getting, and I find it hard to recommend to someone when we're not exactly sure what we're doing. So I would, recycle old, if you had a medication that worked in the past, to recycle old medications, something that neurologists, will do, but it's often a good thing to do, is, reach back into your old bag of tricks and pull something out. And then, wait till cannabidiol becomes approved. And hopefully, with all the data that's out there for outside of LGS and Dravet, that insurance companies would actually be willing to allow physicians to prescribe it off label, because there's good data supporting it.
Okay, thanks. Next question is relating quality of life to seizure medications and some of the side effects. I've had many parents comment to me personally that their girls seem to be, very neurosensitive, that a much smaller dose seems to do the trick, and the standard starting dose that neurologists want to, usually start with a patient can have extreme side effects. Do you have experience with that? And what are some ways to, again, have a positive dialogue with your neurologist to get to a good quality of life and try to get seizure control?
Yeah, so that's, so I agree that I've seen in my patients with Rett that some of them are very sensitive and will do well or have side effects on a low dose. So, if your child seems to be sensitive, to talk to the neurologist about starting lower. There's no harm in starting lower, just a little bit more time. And if you're dealing with seizures, again, you don't have to chase every seizure, so it's okay to start lower. And then it is a balance between seizures and side effects and quality of life. And that, every family has a different take. I have families who hate seeing seizures and want to try and keep on trying. And I try to convince them, let's just stay where we are, but they want to adjust, they want to go up, they want to do that. And there are other families who are like, yeah, these medicines are terrible. She's happier without any medication or just minimal. Let's do that. So, it is a conversation that you need to have. There's no right answer to how one handles this. And, you could be very aggressive, do lots of medications, but if the child's sleeping all the time or irritable from it, it's not worth doing. So you really have to balance all this together. Does that answer the question?
Yeah. I think so. I'll let the parent write in and let us know if she's satisfied with that answer, but I think it was pretty complete. Next question is, how do you start weaning off a seizure medication? So daughter is 21, has been doing really well, has been on medication, but hasn't had a seizure in a very long time. So are seizure medications, addictive? Is there withdrawal issues? How, I'm sure that varies by medication, but what is that process? How should it look?
Yeah, so the first thing to say is that you don't want to cold turkey a seizure medication, not necessarily because they're addictive, but you can imagine the brain has gotten used to this medication on board. So any rapid change could potentially induce what we call withdrawal seizure. That's not because they're addicted, but because the brain is expecting something. So, if you, in the case where the child's done really well, has been seizure free, I particularly in those cases like to go slower because they've been on the medicine for a while. An extra couple months isn't going to hurt. So I would say potentially go down by 10% every 2 weeks and take, 20 weeks or 4 months to get off of it. Other people would say, no, you can take it off after a month. There's no science behind this. It's just kind of a feeling that you have. I weigh into the fact, what was the seizure beforehand? If the seizure was a complex partial, just some brief staring for 30 seconds, you could be more aggressive because if it comes back, there's no harm. If the seizure was status beforehand, you might want to go a little slower. So, the point would be to not just cold turkey medication and come up with a weaning plan that should be anywhere from 3 weeks is the short end, 2 to 3 weeks is the shortest end you would wean off a medication, to a few months, the longer end. Benzodiazepines, so Valium and clobazam, can be physically addicting, so you do want to go slower with those, but a couple months is long enough to wean someone off from those medications.
Okay, thanks. I'm going to jump ahead to a related question. There was a mom whose daughter is on 3 medications, and you had sort of said that may be too many, but she feels those 3 are great, working fine, and isn't wanting to change. You okay with that?
Yeah. So, if the child's doing great, don't rock the boat. If don't rock the boat. And after a little bit of time, if you then want to say she's still doing great, maybe we can take one off, that's a discussion to have. But yeah, no, I am perfectly fine. Someone comes to me seizure-free on 3 medications, I'm not going to mess with that. If they come to me seizure-free, but they say they're tired all the time, then I would probably try to pick one to come off. But if you're doing well, don't mess with it.
Okay. One right before that is parent heard that Topamax has a high incidence of or possibility of causing kidney stones. Can you talk about that? How long can someone be on a drug before worrying about something like those kinds of side effects?
Yeah, so topiramate is known. It's a described side effect of developing kidney stones. It has some carbonic anhydrase inhibition, which can acidify things, which can cause stones. It is more of a what we call idiosyncratic reaction, as in that it kind of occurs out of the blue. So it's not dose or time related. So it's something that can happen if you've been on it for a month or been on it 5 years. So it's something that just needs to be thought about if you remain on the medication. If you ever see any blood in the urine, or the child becomes uncomfortable and you don't know why they're uncomfortable and they're on topiramate, you want to think about, do they develop kidney stones? So it is something you need to look for, but there's no absolute time before it's going to happen, because it can kind of happen out of the blue.
Okay, thank you. We are at our time limit here, and we do have quite a few more questions that have come in. So let me ask one more question, because it was asked twice, 2 different ways, and then if we can, we'll take the rest of them offline. And I've got a few just closing remarks and reminders for the community. You had mentioned that there are 2 drugs that seem to have interaction issues with CBD. One is Onfi, and the other one clobazam. Can you
okay, go ahead.
Maybe. What was it?
Depakote, valproic acid.
Depakote. Yeah. Okay. So, what are the side effects? What are the problems?
Yeah, so the problem with Onfi is that the level goes way up, so the kids become very sedated. We've had some kids who were very sedated when you add CBD to clobazam. And then Depakote, it actually kind of bothers the liver. So the liver enzymes bump up. In all of the GW studies, there was no fatal liver toxicity or no significant or no major liver toxicity, but there were kids who needed to come off it because their liver enzymes really changed. And then also with Depakote, platelets can drop when you add CBD to Depakote, and that can cause bleeding. And so that's something that you really have to be aware of.
Okay. All right. Thank you. I thought those were important questions because I know parents are doing a lot of exploring in these areas. So we do have quite a few questions. Like I said, I'll get those into a Word document and over to you, Dr. Marsh, and we'll get them answered in your limited time. I know you're very busy, but I just can't thank you enough for taking the time for being with us today. I've had the opportunity to visit your clinic and meet both your clinical staff who work with the families as well as the folks working in your lab. And I just have to say, I think from top down, you have built an incredible team, and they all seem to have the same level of intensity and empathy and connection to our families that you do. And I appreciate that. And anyone who has a chance to get to go to your clinic or lives nearby and hasn't had a chance to make an appointment, please do so. Please consider enrolling in the natural history study, and I promise that you will benefit from your time with Dr. Marsh.
Well, thank you for such kind words.
Yeah. There's a complimentary RettEd webcast that we did in June. Dr. Bernard Suter, who is a movement specialist, did a webcast for us. And he talked a lot about the difference between dystonia and identifying the difference between Rett episodes and seizures. I think that for those questions in the queue that were connected to how, again, really trying to differentiate between what is an episode, what is a seizure, what do you treat, when do you treat, and how do you treat, please go back and look at that RettEd webcast from June, revisit this one, and then let me know if you still have questions.